Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article, Cancer Susceptibility Gene Mutations in Individuals with Colorectal Cancer by Matthew Yurgelun et al. My name is Jim Ford, and I'm a professor of medicine and genetics in the Division of Oncology at Stanford University School of Medicine in Stanford, California, where I direct our program in clinical cancer genomics and practice medical oncology. Colorectal cancer is the third most common cancer in the United States, with a median age of diagnosis of around 70 years. Population-based endoscopic screening has led to a decrease in incidence and mortality and is recommended every 5 to 10 years for those 50 years or older. However, with this rising incidence among adults younger than 50, there may be individuals who would benefit from earlier or more frequent screening, particularly those with a familial or genetic predisposition. Indeed, with the recent uptake of universal screening for DNA mismatch repair gene defects and microsatellite instability, termed MSI, in most, if not all, newly diagnosed colorectal and endometrial cancer cases, many individuals and their family members now diagnosed with Lynch syndrome undergo more intensive screening for these and other cancers starting at a much younger age. Advances in next-generation DNA sequencing now allow for panels of cancer susceptibility genes to be analyzed for pathogenic mutations from germline DNA in a time frame and cost competitive with what was recently standard for single-gene testing. This has resulted in a rapid transformation in genetic counseling and testing practices, with a significant move toward multi-gene panel testing for individuals with any personal or family history of cancers, rather than restricted to those meeting traditional criteria for classic Mendelian syndromes, for example, the Amsterdam criteria for Lynch syndrome. Accordingly, over the past several years, a number of clinic-based studies have found that a significant number of individuals with high-risk personal and/or family histories of cancer harbor germline mutations in cancer susceptibility genes other than those predicted for based on classic syndromic criteria, on the order of 5 to 10%. However, the prevalence of germline cancer susceptibility gene mutations in colorectal cancer patients unselected for high-risk features, such as young age, family history, or MSI, remains unknown. In the article that accompanies this podcast, Matthew Yurgelun and colleagues at the Dana-Farber Cancer Institute in Boston and Myriad Genetics provide an important and timely analysis of this very question. This retrospective study used germline DNA extracted from blood samples collected from 1,058 consecutive colorectal cancer patients seen at the Dana-Farber for Cancer Care from 2008 until 2014, who agreed to participate in this IRB-approved protocol. All samples underwent germline DNA sequencing on a 25-gene panel, ultimately named the Myriad MyRisk test. This was performed on a research basis, and results were not returned to patients or their families. Clinical information was gathered from medical record reviews and study-associated questionnaires. The results are quite provocative. Approximately 10% of all colorectal cancer patients were found to harbor a germline pathogenic mutation in one of 25 cancer susceptibility genes, a number remarkably similar to multiple other studies in high-risk populations from these authors and other groups. 3% were ultimately shown to have Lynch syndrome, exactly as expected and supportive of universal MSI testing. 1/3 were found to have a variant of unknown significance, or VUS, in at least one of the 25 genes, again, exactly as expected from other studies of multi-gene panel tests. But what was unexpected is that 7% were found to have pathogenic mutations in genes other than those associated with Lynch syndrome, and 2/3 of these had no family history suggestive of other hereditary cancer syndromes. Particularly notable was the finding that 1%, or 11 cases, had a germline mutation in BRCA1 or BRCA2. 4 times what is thought to be the population-based incidence of mutations in these genes. And 70% of these had no personal or family history consistent with hereditary breast or ovarian cancer syndrome. Furthermore, over half of all mutations were found in colorectal cancer patients older than 50 and without any family history of colorectal cancer in first-degree relatives. 10%, or 34 of 336, of patients diagnosed younger than 50 had a non-Lynch syndrome gene mutation. This study has many strengths and is an important first step to answering the question of what is the population-based mutation frequency in colorectal cancer patients, irrespective of high-risk features. Certainly, the finding that 7% of all colorectal cancer patients carried mutations in non-Lynch syndrome genes on the panel, over half of which are considered high penetrants for a variety of cancers, such as BRCA1 and 2, suggests consideration of a major change in how we select patients for germline genetic testing. There are some weaknesses and limitations to the study that are also important to consider. It is retrospective and based on a highly selective cohort of patients who are referred to and receive care at a tertiary cancer center, and thus not truly population-based. The study design, unfortunately, did not allow for return of genetic test results to participants, and so the real-world effects of these often unanticipated results on patient and family member cancer screening and management could not be determined. Perhaps most important from a scientific point of view is that although the incidence of non-Lynch syndrome mutations was well above expected, true causation in individual patients could not be proven. This will require functional genomic studies on the tumor specimens, such as analysis of loss of heterozygosity, consistent with Knudsen's two-hit hypothesis, or pathway-specific defects, such as widespread copy number variations associated with altered homologous recombination, as would be expected in BRCA1 or 2 mutation carriers. Of course, this is a major challenge for the whole field and well beyond what could be accomplished in this retrospective registry-based study. Most importantly, the obvious implication of this study is to consider testing all or some major subgroup of colorectal cancer patients with a multi-gene panel. Another important study recently published online by Heather Hampel at Ohio State and colleagues representing the Ohio Colorectal Cancer Prevention Initiative in JAMA Oncology on December 15, 2016, found using an identical germline multi-gene panel in a prospective analysis of 450 colorectal cancer patients diagnosed under 50 years old that 16% had germline pathogenic mutations, half of them in non-Lynch syndrome genes. Historically, cancer genetic counselors considered a predictive chance of finding a germline mutation in an individual of about 10% to be reasonable, and that is consistent with the current findings for all colorectal cancer patients of any age. Of course, studies to clearly demonstrate the clinical utility of such an approach will be critical, as well as cost-benefit analyses incorporating screening tools such as colonoscopy. Published guidelines, such as those updated annually by the NCCN, will need to support this based on high-level evidence. However, one approach that seems quite reasonable and will provide clinical impact now is to offer comprehensive multi-gene panel testing to any colorectal cancer patient diagnosed under the age of 50 and to those 50 or older who exhibit the MSI phenotype or have a family history in their first-degree relatives. This concludes this JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.